So our first topic for today is hemolytic anemias. Yesterday we discussed microcytic, macrocytic, and normocytic anemias. Now, anemias which do not fit into this classification, they are known as hemolytic anemias. Yesterday we discussed that hemolytic anemias can cause normocytic anemia or they can cause macrocytic anemia. Hemolytic anemias will cause macrocytic anemia if the number of immature RBCs are more than 2%. So at a high reticulocyte count, hemolytic anemias will cause macrocytic anemias. Otherwise, they will cause normocytic anemias. Now, before we discuss the causes of hemolytic anemias, first, you need to know some general things about hemolysis, that what will happen in the body if hemolysis is going on. So hemolysis is basically a premature breakdown of RBCs before their normal lifespan of 120 days. So how we are going to know if hemolysis is going on? What will happen if there is hemolysis? The first thing that will occur in response to hemolysis is increase in the formation of or bone marrow will try to compensate hemolysis by forming RBCs, and these RBCs will be released into the circulation prematurely. So in short, you can say that to compensate hemolysis, there will be reticulocytosis or reticulocytes, which are immature RBC, they will increase in the circulation. So hemolysis is compensated by reticulocytosis. Now, what are the other points to identify hemolysis? If there is a hemolysis, a breakdown of RBCs, the person will develop anemia. So the first thing for hemolysis is anemia with normal or increased MCV plus reticulocytosis. So if there is a breakdown of RBC, what will happen? We all know that RBCs contain hemoglobin. And when there is breakdown of RBCs, hemoglobin will be released from the RBCs, and the heme part of this hemoglobin will be converted into bilirubin. So anemia with jaundice or increased bilirubin will be hemolytic anemia. Because there is increased formation of bilirubin, so bilirubin will be excreted in the urine as well. So someone with anemia and signs of jaundice, such as yellow discoloration of eyes or skin or dark color urine, then you will suspect hemolytic anemias. So the hemolysis causes anemia. Second, it causes jaundice. Third, it causes dark color urine. Now the fourth thing is an enzyme, that is lactic acid dehydrogenase or lactate dehydrogenase, or simply LDH. LDH is an enzyme which is released by the red blood cells when there is hemolysis. So these are the few things by which you can identify hemolytic anemias. So first, you need to look at the complete blood picture. Bilirubin level and LDH level to identify if there is increased red blood cell breakdown. So someone with anemia, yellow discoloration of skin and eyes, or dark color urine, and increased LDH and reticulocyte count, you will suspect hemolytic anemias. So now we will discuss some causes of hemolysis, that why hemolysis occurs in the body. So three things you need to remember the causes of hemolysis. That is enzyme deficiency, and the second one is defect in the RBC membrane, and the third one is defect in the hemoglobin that is present inside the RBCs. So if there's defect in any of these three things, hemolysis will occur. Enzyme deficiency or enzyme defect that are present in the RBC membrane, or RBC membrane defect, or defects in the hemoglobin. Enzyme defects such as glucose 6-phosphate dehydrogenase deficiency, it can cause hemolysis. How it can cause hemolysis, that we will discuss shortly. Membrane defects such as hereditary spherocytosis can also cause hemolytic anemia, and hemoglobinopathies such as sickle cell anemia and thalassemia, because both of them are hemoglobinopathies, so they can cause hemolytic anemias as well. These are some hereditary causes of hemolytic anemias. Acquired causes of hemolytic anemias, they include autoimmune hemolytic anemia, microangiopathic hemolytic anemia, and infection such as malaria, and paroxysmal nocturnal hemoglobinuria. They are the acquired causes of hemolysis. We'll discuss one by one in detail these causes of hemolysis. And when we'll suspect hemolytic anemias, anemia with signs and symptoms of jaundice and increased LDH and reticulocytosis, we will suspect hemolytic anemias. Now, how to diagnose different causes of hemolytic anemias? Now, we'll discuss it one by one. So, first of all, the first thing is the enzyme defect that can lead to hemolysis or premature breakdown of RBCs, and that enzyme is G6PD, glucose 6-phosphate dehydrogenase deficiency. So, what will happen if there is deficiency of G6PD? It is the commonest red blood cell enzyme defect. Remember that whenever there is deficiency of G6PD enzyme, it results in reduced glutathione. When there is a reduced glutathione, G6PD enzyme is required for the formation of glutathione. And glutathione protects the cell against the oxidative stress. So when there's a low G6PD, what will happen? Glutathione will also decrease, and a decreased glutathione expose the red blood cell membrane to oxidative stress. So when red blood cell membrane is exposed to oxidative stress, what will happen? It will result in premature hemolysis of the RBCs. G6PD deficiency is an X-linked disease, and we all know that X-linked diseases usually affect males. So for Plab 1 exam, remember that hemolytic anemia in males, the cause may be G6PD deficiency. Most individuals with G6PD deficiency are asymptomatic and unaware of their status. When they will know that they have G6PD deficiency, because normally they are asymptomatic, There are some drugs which can precipitate hemolysis in a G6PD deficiency. These drug include anti-malarial drug. The most common one is anti-malarial drugs such as primaquine. Other than anti-malarial drugs, ciprofloxacin, sulfonamides, sulfasalazine, and sulfonylureas, they can also cause hemolysis in patient with G6PD deficiency. The important one is anti-malarial drug primaquine. So remember this one. The drugs that are safe in G6PD deficiency, they include macrolides, tetracycline, penicillin, cephalosporin, and trimethoprim. Now, how a patient of G6PD deficiency will present to you. If someone develops hemolytic anemia after taking a drug such as primaquine, there are four ways the patient might present in Plab 1 exam. What are those four scenarios? The patient in which the patient might present to you, or in which they ask you question in Plab 1. The first one is drug-induced hemolysis. That is, if a person develops hemolysis after intake of primaquine, an anti-malarial drug. So a person took primaquine and he developed hemolysis. How we are going to know that the person has developed hemolysis? If he developed anemia with jaundice, then we will suspect hemolysis. So this is the first scenario. That is drug-induced hemolysis due to primaquine most commonly. Hemolysis usually begin 1 to 3 days after injection of the drug, and anemia is most severe after 1 week of injection. And in case of drug-induced hemolysis, you will see Hens bodies and bite cells on peripheral smear. Hens body inclusion and peripheral smear. I will show you the diagram of Hens body and bite cells shortly. For now, just remember that in drug-induced hemolysis in G6PD deficiency, there will be bite cells or Hens body on peripheral blood smear. Hemolysis so either a drug such as primaquine can induce hemolysis in G6PD deficiency. The second cause of hemolysis in G6PD deficiency is infection. So someone with a history of infection or fever and he developed hemolysis, then again we'll suspect G6PD deficiency. And the third one is favism. Fava beans, after ingestion of fava beans or broad beans, if someone develops hemolysis, then again we'll suspect the G6PD deficiency. And don't forget the signs of hemolysis. The signs of hemolysis is dark colored urine, yellow discoloration of the eyes and skin, and fatigue or pallor. So anti-malarial drugs such as primaquine, infection, and fava beans, these three things can induce hemolysis in patient with G6PD deficiency. And the fourth way the patient might present in Plab is that someone with a history of neonatal jaundice. Someone who has a history of neonatal jaundice and now again present to you with hemolysis in adulthood, again you will suspect G6PD in deficiency. So these are the four types of scenario which can be asked about G6PD deficiency in Plab 1 exam. Now, what is the initial investigation in case of G6PD deficiency? Remember that another risk factor, though it's very rare, that the use of henna can cause life-threatening hemolysis in G6PD deficiency, but still it has a potential risk of inducing hemolytic anemias in patient with G6PD deficiency. So that's why use of henna should be avoided in G6PD deficiency.
Question.
Yes.
How does that process occur if someone wears henna and it
If
sets off hemolysis?
Topically applied henna can the chemicals that are present in henna they can be absorbed through skin in the blood vessels, and they are it can expose the body. They are very oxidative. They can cause oxidation, so that's why the use of henna can precipitate a hemolysis in patient with G6PD deficiency,
Okay.
because henna
Thank you.
contain oxidative chemicals like fava beans. So that's why it should be avoided in G6PD deficiency. Got it?
Yes, sir. Thank you.
So the initial investigation in G6PD deficiency will be a complete blood count with peripheral smear, and peripheral smear will show Hens bodies and bite cells. Let me show you Hens body and bite cells. Hens bodies are basically inclusions that are present in the RBC. You can see in this diagram, this is a picture of a peripheral blood smear, and you can see these blue dots inside the RBC. These blue dots are basically denatured hemoglobin, and they are called Hens bodies, and they are present in drug-induced G6PD deficiency on a peripheral blood smear. So when these cell passes through spleen, the spleen take a bite of these Hens bodies and result in the formation of bite cells. So in this diagram, you can see that this cell is just like a cell from which a bite has been taken. So this is a bite cells. So bite cells and hand bodies are seen on a peripheral blood smear in G6PD deficiency. Remember this point, the finding of a peripheral blood smear in case of G6PD deficiency. Other than Hens bodies and bite cells, blister cells can also be found. Blister cells are also just like a bite cells. You can see in this diagram a fragmented RBCs. Hens bodies and bite cells are more important. Blood blister cells can also be found. They are, you can say, a variant of bite cells, or they are just like bite cells. So the initial investigation in case of G6PD deficiency is peripheral blood smear with complete blood count, and it will show Hens bodies and bite cells. Also spherocytes may also be present, and RBC fragments may also be seen. Spherocytes and RBC fragments, they can also be present in other hemolytic anemias, so they are not specific for G6PD deficiency. What are the other lab findings? As we discussed already, that all causes of hemolytic anemia will have macrocytic or normocytic anemia, along with increased unconjugated bilirubin due to increased breakdown of RBCs. Increased bilirubin will be formed, and liver will not be able to conjugate it, so increase unconjugated bilirubin. And because when RBC is broken down, hemoglobin is released from these RBCs, and these hemoglobin combine with a plasma protein haptoglobulins, and this combination of haptoglobulin and hemoglobin is then removed by the reticuloendothelial system of the body. So decreased haptoglobulin is also a sign of hemolytic anemia on lab investigation. And the other lab finding is increased reticulocytosis. So these findings, they will be common to all causes of hemolytic anemias. That is increased unconjugated bilirubin, decreased haptoglobin, and increased reticulocytes. The definitive test is G6PD enzyme assay. G6PD enzyme assay. Remember that the cells, the newly formed cells in response to hemolysis that are reticulocytes or the immature RBCs. In immature RBCs, G6PD enzyme levels are normal. So that's why this G6PD enzyme assay will be done 6 weeks after the episode of hemolysis or after the acute attack. Why G6PD enzyme assay is done 6 weeks after the acute attack? Because reticulocytes have an increased level of enzyme G6PD. That's why if we check G6PD enzyme during the acute attack, it will result in abnormal results. So the initial investigation include peripheral blood smear, which will show Hans bodies and white cells. Also other lab investigations or that are common to all type of hemolytic anemias, and the confirmatory or most important diagnostic test is G6PD enzyme assay. Now some points about the management of G6PD deficiency. First of all, we will avoid what?
Can you please repeat for the unconjugated bilirubin how it is raised?
Because there's liver bilirubin is conjugated in the liver, and liver has a limited capacity to conjugate bilirubin because the enzymes that is required for conjugation that is also in a limited quantity. So what
Oh,
happens in hemolysis that there is increased RBC breakdown. So increased RBC breakdown will release increased amount of hemoglobin, which will be converted into increased amount of bilirubin. So the bilirubin is more than the capacity of liver to conjugate. So that's why though conjugated bilirubin will also be increased, but unconjugated bilirubin is increased more than the conjugated bilirubin
okay.
because of increased formation of bilirubin.
Right. Right. And you said something about hepatoglobulin.
Haptoglobin. Haptoglobin is a plasma protein that transport the uh, that combine with the and transport this free hemoglobin. Normally, hemoglobin is present inside the RBC, but when it is released, it combines with the haptoglobin. Then this haptoglobin form a soluble complex with the hemoglobin, and then it is removed from the body. So
Okay.
because of increased release of hemoglobin from RBCs and increased utilization of haptoglobulins, haptoglobulin levels will also decrease.
Okay. Thank you.
So the management is very simple. Avoid the breastfeeding drug or fava beans, and if there is a severe hemolysis or symptomatic anemia, so symptomatic anemia and HB less than 7 will transfuse blood, and asymptomatic anemia with HB less than 8 again will transfuse blood. So remember these indication for transfusion of blood in every case of anemia. IV fluids to maintain good urine output, and in infants exchange transfusion may be required. And if there are severe cases of recurrent hemolysis, then splenectomy may also be of value. So the management is supportive, that is transfuse blood if anemia is severe or symptomatic, and IV fluids to maintain a good urine output, and in infants exchange transfusion may sometimes be required. And if the attacks are recurrent, the attacks of hemolysis are recurrent, then splenectomy may also help in relieving the symptoms. Now, a comparison of G6PD deficiency with hereditary spherocytosis. One difference between these two is that G6PD deficiency is an X-linked recessive disease. So it will mainly or mostly affect males, while hereditary spherocytosis is an autosomal dominant disease. So it affects male and females both. And the second difference that you need to remember between these two is that G6PD deficiency is common in African and Mediterranean descent, and hereditary spherocytosis is common in European descent. So European people in European people, hereditary spherocytosis is more common, and in G6PD deficiency um, is more common in African and Mediterranean people. Both of them, G6PD deficiency and hereditary spherocytosis, both of them can cause neonatal jaundice as well as hemolysis. So this is the history is usually common. That is neonatal jaundice, and drugs and infection can precipitate hemolysis. Similarly, in hereditary spherocytosis, uh, though there are no drugs that can precipitate hereditary spherocytosis, hemolysis in hereditary spherocytosis, but infection such as infection with a parvovirus B19, it can induce hemolysis in patient with hereditary spherocytosis. And because of increased formation of unconjugated bilirubin, gallstones can be formed in all causes of hemolysis. So hemolytic anemia can lead to formation of gallstones as well. The peripheral blood film will show Hens bodies in case of G6PD deficiency and hereditary spherocytosis. There will be spherocytes. Normally, the shape of RBC is uh, a biconcave disc-shaped RBCs are present normally in the blood, but spherocytes are round RBCs. How you can differentiate between spherocytes and normal RBCs on a peripheral blood smear? You can see in this diagram that there are some cell with a central white area and a peripheral red area. So this is a normal RBCs. The RBCs which has a central pillar surrounded by a red area. These are a normal RBCs that are. This is due to the biconcave disc shape of the RBCs. But what happens in hereditary spherocytosis? Circular RBCs that are called spherocytes, they are found, and these spherocytes, they don't have any central pillar. You can see that all of these cells do not have any central white area or central pillar. So these cells are known as spherocytes. So if spherocytes are present on a peripheral blood smear, then it is most likely due to hereditary spherocytosis. Remember that there is one more condition in which we can see spherocytes on a peripheral blood smear, and that is autoimmune hemolytic anemia. So in short, if there are spherocytes on a peripheral blood smear, the diagnosis can either be hereditary spherocytosis or it can be autoimmune hemolytic anemia. While in case of G6PD deficiency, there will be Hens bodies or bite cells on a peripheral smear. So this was all about G6PD deficiency and its comparison with hereditary spherocytosis. Both of them are causes of hemolysis. One is due to enzyme deficiency and the other is due to RBC membrane defect. So now some key points in this topic. They include If you see in Plab 1 antibodies on a blood film, you can be almost certain that this is a G6PD deficiency. So whenever you see antibodies on a peripheral blood smear, it will always be G6PD deficiency. Antimalarial drugs such as primaquine, they are the main precipitator of hemolytic anemia in G6PD deficiency patients. And the definitive test for G6PD deficiency is a G6PD enzyme assay that is done 6 weeks after the acute attack is settled. So this was all about the first cause that we discuss of hemolytic anemia, that is hereditary spherocytosis. So in hereditary spherocytosis, hemolysis of the RBCs occur due to deficiency of the enzyme G6PD. Now we'll move towards the second cause of. So we have started from the RBC membrane, and we are discussing the causes of hemolysis. So the first cause that we discussed, it was caused by an enzyme deficiency. Now the second cause is caused by a defect in the RBC membrane. A defect in the RBC membrane that lead to hemolysis. 2 minutes are remaining.